So my name is Cooper Davis. I'm Executive Director of Intercompass Initiative, which is a nonprofit organization who for the past 10 years, we've been helping families, individuals, make more informed choices around psychiatric drugs, psychiatric diagnoses, and in particular, around tapering and withdrawal for people who decide, for whatever reason, they might not want to continue on these drugs. And there's more and more people on these drugs than ever. And so accordingly, there's more and more people who are interested in coming off. And our nonprofit, and this is a more general panel, just speaking, this is why I'm the guy moderating this, that's the experience that I come from. And so we're sort of connected to the mental health crisis, which is something a lot of people are calling it right now, from the direction of lay people. So we're not a clinical organization. We're more on the patient side or ex-patient side. So my fellow panelists and I are very grateful to have been invited here today and be a part of this. And I think that probably everybody in this room is plugged in enough to have heard that we have a mental health crisis happening in the United States. That's a pretty bipartisan conclusion right now. I don't think that's controversial, but what is controversial and where there is a lot of disagreement is why is that? Why do we have this crisis? So most people can agree that it qualifies as a crisis, but what is going on? And so that's what I hope this panel here, that I'm happy to be up here with, that we can, I don't know if we'll solve it, guys, but we'll give it a college try. And for the sake of expediency, I'm just going to go ahead and introduce you all. And so, forgive any errors. Here it comes. So we have Matt Bernstein from the University of Pennsylvania, a Harvard-trained psychiatrist. He's a full-time clinical psychiatrist for 25 years, and he's the founder of Accord, which is a really interesting and innovative thing that they have going on. It's described as an immersive metabolic psychiatry program in Massachusetts. And he's also the organizer of the very first public metabolic psychiatry conference. And that's certainly one of many to come, I suspect. Gretchen Lefevre-Watson is here with us, clinical and pediatric psychologist. She was the first researcher to document the overuse of psychotropics to treat ADHD and the prescribing cascade that often results from starting a child on a stimulant. That's an experience that is familiar to me and probably a few other people in this room. For doing that and for demonstrating the effectiveness of no-drug alternatives, she was falsely accused of being an anti-medication zealot who had engaged in scientific fraud. So congratulations, we're happy to have you here, Gretchen. And then we have over here, we have Joseph Witt-Doering. He's a board-certified psychiatrist himself. He's also a former FDA medical officer, and he is the co-founder of the largest psychiatric drug tapering clinic in the world. That's a big deal. And he's also published what I think is pretty excellent guidance, and there's not a whole lot of this type of guidance out there yet, on benzodiazepine and antidepressant deprescribing. We might use the terms tapering and deprescribing interchangeably here, but just a slow, gradual reduction down to zero. Just think of it that way. And then we have over here Laura Delano. She's the founder of the organization that I now run. She's also the author of a book called Unshrunk, A Story of Psychiatric Treatment Resistance, which is her own memoir. Highly recommend. And she has traveled quite a bit, speaking on issues of informed choice and community-based, layperson-led alternatives to the medicalized mental health system. And so it's a really impressive panel, I have to say. And without further ado, I just want to jump right in with Gretchen, actually. As I mentioned earlier, we do see broad bipartisan agreement that Americans, and especially young Americans, are struggling more than ever. But there's a lot of, like I said, there's a lot of disagreement about where those struggles come from. Is it screen time? Is it the loss of the nuclear family? Is it just like modernity poisoning? Is it the food, the glyphosate? What is it? You've been doing this for a while, and I'm wondering if you could sort of, as someone who's been tracking trends, especially in youth mental health for decades, what is your sense of what might be going on here?
Great question. Yes, yes, yes. It's all the things that Cooper just mentioned. But I think one of the most potent driving forces behind this crisis, particularly the youth mental health crisis, is also the most overlooked factor, and that is a widespread overprescribing of psychotropics. The more we prescribe these medications, the worse our children's mental health becomes. And I'm just going to take ADHD for a moment to talk about that, because that's the most common child mental health diagnosis. It's often a gateway diagnosis, and it's supposedly one of the most benign child mental health diagnoses. But what happens is, once a child is diagnosed with that condition, they're almost always medicated for the condition sooner or later. And in this country, every year for the past 25 years, the number or the proportion of medicated children just keeps going up and up and up. And we're told that the medications that are the first line of defense, the stimulants like Ritalin and Adderall, are basically safe and effective. But what we're not told is that these drugs, when used at higher and higher doses or for longer and longer, tend to produce adverse effects and side effects that look like other mental health symptoms. So a child gets diagnosed with ADHD, put on Ritalin or Adderall, and then all of a sudden they're having mood problems, and parents are told, oh gee, you know, Johnny or Susie's mental health condition is more serious than we first realized, or it's deteriorating, or they actually have multiple mental health disorders. So you see a piling on of diagnoses and medications, and before you know it, children are on what we would call polypharmacy. They're on stimulants, antidepressants, mood stabilizers, and antipsychotics. And you might think that sounds outrageous, but it's not. I mean, it is outrageous practice, but it's not a hypothetical problem. So 25 years ago, I want you to really think about this. We're going back a quarter of a century ago. I documented the rate with which children were being diagnosed and medicated for ADHD in southeastern Virginia, not too far from here, in Hampton Roads, which turned out to be, unbeknownst to me at the time, the epicenter for psychotropic overprescribing, not only in this country, but in the world. So a quarter of a century ago, 19% of elementary children in southeastern Virginia were diagnosed with ADHD. Most of them were medicated. And those children who were medicated, 28% of them were on 2 psychotropics or more simultaneously, 8% were on 3, 1% were on 4. That at the time was completely unheard of, even among adult populations, and yet we're talking about elementary school-aged children. So what I did was I shared that information with my community, because I really didn't set out to be an epidemiology researcher. I was a pediatric psychologist doing clinical practice. And when the local community had access to their local data, they got very engaged, and they supported all these non-drug interventions that we put in place in the community. And we pretty quickly got a 30% reduction in the use of psychotropics while improving educational outcomes on every subject area of the standardized educational test. Well, as you can imagine, ADHD and industry-funded ADHD experts did not like that. Mm-hmm. And so they pulled out all the usual tricks to shut down the research. And what I really want you to think about is, if the public had had access to that information 25 years ago, our mental health, the mental health status of our children would be much better today, I believe. Instead, when we look at ADHD today in this country, more than 40% of children between 2 and 24 years of age who are medicated for ADHD are on antipsychotics. Those are psychiatry's big guns. We used to use those only for the most severely mentally ill adults, basically schizophrenics who you think of as being in the hospital. And now we have toddlers who are on these medications. And it is making them not only mentally sicker, it's turning otherwise normal children into chronic psychiatric patients. It's also making them physically sick because it contributes to weight gain and obesity. So I'm very, very excited that the MAHA executive order specifically calls for an assessment of the prevalence and threat of psychotropic drug use. And I'm really motivated to help that get put in place. And maybe we'll have time to talk later about how we can now readily get local data and trends in the hands of local communities, which used to require a lot of heavy lifting, but it doesn't need to anymore.
Thank you so much, Gretchen. And you're ending on a sort of fascinating note, which is certainly worth more conversation. Before we move on, I'm sure our panel between us, if that's where we were 25 years ago and just on ADHD, or back then it was ADD. Right?
It was evolving to ADHD,
moving.
Yeah.
But do we have some sort of like general statistics for the audience about the rate of psychiatric drug prescription in the United States?
I mean, I can speak to that. So data from 2014, we have about 14% of the US population now taking antidepressant medication. It's about 8% of men, and it's nearly 18% of women in this country. When you go up to around 50 years of age, it approaches 30%. It's a huge amount of our population on these meds. 20% of Americans now take psychiatric medications, and they're not working because back in the early 90s, there's something we call treatment resistance in psychiatry, and that's people who don't respond to the medications or they wear off over time. We had a treatment resistance rate of about 10% in the early 90s. Data that came out this year shows that it's about 50%. So what does that mean? It means that the drugs aren't working for nearly half of the people on antidepressants, and it's probably because they're causing tolerance. And so the statistics show that we're using more and more drugs and we're not getting better outcomes. Yeah.
Thanks. And, I think it's worth saying that we have quite a lot of data, but not nearly as much as we need, right, on the effect of these drugs. And it's worth saying also that all drugs, psychiatric or otherwise, have trade-offs. There's risks and benefits, and ideally the idea is to sort of balance those out in each individual instance and have somebody who knows what they're looking at kind of monitoring what those trade-offs look like, certainly at the beginning, but also over time. Laura, I think if you could talk a little bit about when people are first making that choice, what ideally should be an informed choice, what is often the case, whether drawing on your own experience or the people you've spoken to over the years of doing your work, what information are patients not getting, or family members, parents who are making these choices on behalf of their own children? What information is not getting through at that point, such that whatever choices they are making aren't necessarily fully informed?
Yeah, I mean, it's an important question, and I think it sits at the heart of this whole conversation because this is a nuanced issue, and many people, for all kinds of reasons, feel helped by these drugs. So it's about enabling people to make true choices, not framing this conversation as being about drugs are good or drugs are bad. And in my case, as someone who was one of these children, I got sucked into the juvenile bipolar trap in the mid-90s, which was right as that diagnosis was taking off and drug companies were expanding market share into this untapped population of angry, irritable, despairing adolescent children who hadn't yet been pathologized. My parents were told at that time that I had this incurable illness in my brain that I would have for the rest of my life and that needed to be managed with drugs. And that is the story that, and not drugs, medicines, medications. That's the story that drives this massive industry of mental health. We are told that when we are feeling emotional pain or we stop sleeping and we get wacky and spin out, that these are so-called symptoms of a medical condition in our brain, some kind of pathology that needs treatment in the way that someone with type 1 diabetes needs insulin. That is the story that we are told. And as long as we are being told that story, none of us are making informed choices, because that is a story that is pure marketing language. There's zero scientific evidence based to any of that. And we weren't told that. My parents weren't told that, and I wasn't told that. Had I been told or had my parents been told that my intense struggles, because I was really struggling, I was cutting my arms and I was getting rough and physical and I was screaming and thinking about death, like I was having a hard time, I needed help. But had we been told, Laura's clearly responding to what's happening in her life, what maybe the food she's eating, maybe the pressures she has at school. So clearly these difficulties she's having need support, but I'm just going to let you know, if we put her on this drug, it's not actually going to fix anything because there isn't actually anything wrong with her. That's the starting point that we need to have any time someone is engaging with a mental health professional of any kind. Beyond that, my parents should have been told, this mood stabilizer and antidepressant that we're about to put your daughter on, these have been approved on the basis of trials that last around 6 weeks. A couple of trials are all that are needed to get this drug approved. Oh, by the way, we've never actually studied these drugs in combination with each other, so we're going to put her on multiple at a time, but we don't actually have any evidence base for that. My parents should have been told that the longer I stayed on these drugs, the greater the odds that my central nervous system would become dependent on them. Because as with any psychoactive chemical taken regularly, your brain will alter itself to accommodate the presence of a drug, whether it's alcohol, heroin, caffeine, nicotine, or Prozac. And what that means is, down the line, if Laura ever wants to have a baby or doesn't want to take this drug anymore years ahead when she's an adult, she might need a really long time and a lot of preparation and an extensive amount of support to be able to safely get off of these drugs. We were, of course, told none of this. And that's just barely scratching the surface of what information a family needs to be given in order to make an actual meaningful choice, setting aside how from day one of medical school all the way through residency, fellowships, continuing education, and beyond, psychiatrists, as with the rest of the medical industry, are infused with knowledge that is in many ways constructed by industry. So for me, if we're going to have a nuanced conversation that we need to have here, because again, this is not about telling people they're bad or wrong for taking these drugs, we have to, at the heart of it, change the language that we use when we're thinking about these issues and talking about them. As long as we are medicalizing these experiences, calling them illnesses, and as long as we are prioritizing professionalized and pharmaceuticalized help, or even medical devices now, that's kind of the new territory of the mental health industry, we're robbing people of the chance to make meaning of these struggles, which are real. Like in 2023, I think it was, 50,000 people killed themselves. That's one person every 11 minutes. I mean, we're really struggling here as a society. We need to have this conversation. But until we kind of reclaim these struggles from this medical framework that has become so monolithic in our cultural understanding of mental and emotional difficulties, we just can't be informed about any of it.
Well, thanks, Laura. I apologize if there were any diehard medical model psychiatrists in the audience. This may not be pleasant, but I think it's also worth saying this what can sometimes be misunderstood as sort of an anti-psychiatry or anti-drug position oftentimes is much more nuanced and is about informed choice, or it's not about, well, it's definitely never a biological, or it's always a biological origin. The reality is we're operating with limited knowledge. As with in all of medicine, but maybe in the realm of mental health, it's this sort of in-between gray area that admittedly is very difficult to operate in, and yet it's sort of a cultural necessity that we've developed different ways of sort of approaching these problems as a culture. And so I'm wondering, Matt, if you would be willing to offer your view, what is our current model, and let's just say the general practice of today that exists in psychiatry in particular, but maybe sort of the mental health professions more generally that tend to draw a lot from psychiatry. What are we getting right? And then where do we have the most opportunity for improvement from where we are right now?
Yeah, thanks. Well, I mean, first of all, I agree with the criticisms. You know, I was an inpatient psychiatrist. I'm a reformed medical model psychiatrist, I should say. But it doesn't mean we can completely throw the baby out with the bathwater. It's complicated. There are people who, you know, kids who started off on a stimulant and then maybe they were prescribed an antidepressant and then traumas occurred and then they end up manic and psychotic and, you know, literally are, you know, near death. I've taken care of those people. I've seen some of these medications save those people's lives. And so we can't completely abandon the fact that sometimes these things are needed. But the analogy I would use is that, let's say someone gets in a terrible car accident and they have multiple broken bones, and we do surgery and we put a cast on them. That's the equivalent of, you know, maybe putting someone on these antipsychotic medications. But then what we do is then say, okay, now you're going to have this cast on for the rest of your life. And that's never been studied, and that's going to impair your walking. And in this case, the analogy I would use is that's going to impair your metabolism and impair your ability to heal over time, and that's never been studied. But go ahead and just wear that cast for the rest of your life because you have this illness that is probably genetic and involves your neurotransmitters, and though we really have never found the root causes or even looked for the root causes of those illnesses, but we know that they're there, you know, we know they're there.
We know that.
Right.
One of these days.
Right. So that's the problem. You know, so I see what goes right is sometimes we do need to use these tools, but they do need to be used much more judiciously, much more thoughtfully, much more with an eye towards, yes, let's take care of the acute crisis, but let's get you off of them while we figure out what is the root cause of what's going on. And there needs to be some urgency to get off of that medication once it's started, if it needs to be started in the first place. And just to add in my part about informed consent, you know, this idea that we're going to really tell people what the risks are and what the benefits are. You know, having operated in an inpatient unit and in outpatient clinics and talking with lots of doctors, it really doesn't exist in our field, because if we did tell people all of those things, most people would choose not to take these medications. And in some cases, they really need to. Like on the inpatient unit, people aren't even, you know, sometimes capable of participating in that conversation. They really need the medication. But that's not an excuse for what happens in outpatient offices.
Thank you for that nuance. I appreciate that, Matt. And I think that from that point, it's worth reflecting again. So we're at this, there's a lot of people who have been coming at this kind of bucket of issues for quite a long time. And I think I speak for a lot of us to say we're pleasantly surprised that the US federal government, but not just the you know, here in DC, but certainly on the state level and also within the culture, there is a new openness and appetite to revisiting the mental health sort of conversation. Part of that is people seeing for themselves up close, you know, instances where it works, where it doesn't, being able to make that judgment for themselves. And then certainly I think part of it is just how drastically it's ballooned. And you know, while maybe the state of our research and our outcomes don't necessarily justify the fact that it's just gotten bigger and bigger and bigger, more and more people on more and more drugs for more and more reasons. So I'm wondering, Joseph, as a former government employee yourself, looking at the opportunity in front of this administration or this, you know, this MAHA movement, what are some places, whether on the policy side or also on the research priority side, that might be worth looking at, you know, sooner than later? You know, where's the low-hanging fruit for people who are engaged on this issue right now?
So the way I would look at this, Coop, is what's the problem, right? So, and this should be relevant for a lot of people in the room. You know, with 20% of people on these medications, we all know someone on psychiatric meds, and we all can imagine the type of care that we would want for them. So let's start there. You know, helping people with their mental health is intuitive. We want to make sure they're physically healthy so their bodies are working. You know, we want to make sure they have nutritious food. We want to make sure that they're moving their bodies. We want to make sure we're not missing medical problems. And then we want to help them with the things that often cause very intuitive issues for people, relationship struggles, existential issues, problems with work. But what we have at the moment is a system where you go and see a family medicine doctor, and after 7 minutes of FaceTime, you get a script with very little investigation into what's going on in your life. You turn up for the follow-up. They don't check in with you and how you're doing. They go, does the med go up? Does it go down? Or does it stay the same? I suspect some people in this room have actually had that experience themselves, given how many people take the medications. Patients will often, they won't get informed consent. They'll get prescribed a drug in an outpatient setting. The doctor will say, well, it's FDA approved, safe and effective. They go to the pharmacist. The pharmacist slides a pad of paper at them or an electronic keyboard where they notate that they've been given an opportunity to ask questions. They pull the drug out, they start taking it, they throw away the piece of paper in there because they assume it's safe, because why else would the doctor and the pharmacist let them take it? And then eventually when it doesn't work, they feel betrayed. They feel betrayed by what's happened. They feel betrayed when they find out that none of the medications have been studied in controlled trials longer than a year. They notice that they become dependent, they wear off, and they start to become trapped. And some of these drugs can be incredibly difficult to come off. And so when we look at addressing this, we need to think about, what can MAHA do to get people the care that we would really want for people that we loved? We would need support for the doctors who are out there looking after people, so that they don't have to look after people in 7 minutes. They can send them to professionals who can help them with lifestyle changes, whether it's diet or exercise, that there is there is a place where they can go and they can meet with professionals for the common things that happen, relationship problems, work issues. So they don't feel this pressure to just write them a script straight away, which could have lasting impacts on their life. And so support like that it could happen in several ways. We could have an NIMH that is less focused on biological research, essentially being sort of a grounds for the pharmaceutical industry to start developing drug-based treatments. We need to move our research agenda away from devices and drugs and towards more lifestyle interventions, so we can prove that they're effective. And then we can get support from CMS and insurance agencies to get the doctors out there on the front line support to get funding for these things, these lifestyle interventions, these therapies. And I think the FDA can also do a better job at informed consent with the medications. There's a serious breakdown with the way we inform people about the risks of these drugs, and our public institutions need to get creative with how we're getting information out there. So I think across all of the different agencies, Coops, there's low-hanging fruit. There's some things that are incredibly hard. Doing research at the NIMH to kind of bolster this, I think will take a long time, but I think it's very well needed. But yeah, it's going to take a lot of time, but the time to start is right now.
Could I quickly add one
Sure.
additional point? So the numbers I found some 2022 CDC numbers that suggest we're almost at 1 in 4 adults on these drugs. And so by my calculations, we have somewhere between children and adults, somewhere between 65 and 70 million people on at least one psychiatric drug right now. And we have 0 off-ramps for them, official off-ramps endorsed by our public and private mental health authorities. None. And think about that, especially knowing what we all know about how these drugs can be so hard to get off of. So for me, a low-hanging fruit is to learn from what's recently happened in the UK, where they have finally, after decades of mostly layperson advocacy, they've finally officially acknowledged that all classes of psychiatric drugs can cause physical dependence and need to be safely tapered. And they've officially incorporated tapering protocols that are mostly informed by those of us in the layperson community who've basically had to figure this out for ourselves over decades through trial and error because there is no research into this. So now the government over there and NICE and NHS have these official guidelines in place. We need those here, and we need them fast, because as more people wake up and begin to question the utility of these drugs, more people are going to want to come off of them. And if we don't have safe, reliable places where they can turn to get the resources and support that they need to get off of them, our crisis is only going to fuel. Because as someone who came off of 5 prescribed psychiatric drugs way too fast because I didn't have good information, I was profoundly disabled for years in withdrawal, and because I had nowhere to turn, no safe, reliable information. So to me, that's a really, I hope that's and we look forward to supporting the new administration however we can in that issue, because it's a real public health crisis.
Sure. Wow, thank you so much for that, Laura. And I think we are just over time. So I think with that, I want to first thank the panel. Thank you guys for this. I also, before we break, I think relatedly speaking, my friend Derek here, I'm wondering if he could just, there's, on the same subject of what we're talking about, some of the best data that exists if you want to analyze the effect of these drugs, that these drugs are having on people. The VA actually keeps really excellent data. And Derek here is a Air Force combat veteran who himself identifies as having had some difficulty with these drugs and has made that a professional interest and an advocacy interest, and he's actually, it's kind of a big deal what he's organizing this June. Do you want to share a little bit, Derek?
Thanks to Leland, thanks to the entire community here for being here and your efforts around all of these issues. John Spagnola, Bob Schwartz, and everybody on this panel, these are the national leaders on this challenge here. I'm an Air Force vet, did 6 years in active duty, 2 deployments to Uzbekistan where I was exposed to chemical weapons and radiation. We were unaware, but a tactical nuke had detonated at that base in '91, and we ended up sending 15,000 troops to that base, and I was there twice. And so fast forward, Afghanistan, got out, wound up starting a national veterans organization called Student Veterans of America, worked in mental health at the VA, built a national mental health program for the VA, got into tech startups in New York. And around that time, I got put on medication, started with Adderall, gabapentin, 2, 3, 4 other drugs. My company's on fire, relationships on fire. I'm packed up, hauled back to Michigan in a U-Haul, and basically couch surfed and was unemployable and all but homeless for about a year and a half, 2 years. And this story is not a unique story as you're hearing today. 70% of veterans under VA care are on a psychiatric drug, so 7 in 10. 30% are on antidepressants. Almost all these medications have risk profiles warning of suicide, and we wonder why we have the veteran suicide epidemic that we have today. And so today I work for the Grunstyle Foundation. We have partnered with the Veterans of Foreign Wars, the Disabled American Veterans, and we're hosting a summit in Washington, D.C. on June 4th and 5th. We're holding a film screening of the film Medicating Normal with panels with the filmmaker, Robert Whitaker, Dr. Peter Gocha is coming here from Copenhagen, a whole list of experts, but the most powerful folks that are going to be in this room and in the U.S. Capitol on June 5th, with a venue sponsored by Senator Moran, is the families. We've got families who lost their 22 and 23-year-old sons after being prescribed mirtazapine and Wellbutrin for 8 days and a month and a half, respectively. The VA's OIG has even found signatory informed consent was not provided. Failure to provide safe medication management, down the list. And so all these issues that my colleagues and friends here have been speaking of are impacting this country in a dramatic way. And if you're interested in working with us, sponsoring, partnering, please grab me. We'd love to work with you. If you know members of Congress that are interested in possibly speaking or being engaged on this matter, please tell me. We're looking for those leaders today. I just want to thank you all for all of your work. You're changing lives, saving lives, and I cannot be more thankful for Secretary Kennedy and President Trump for their executive order calling for action on this issue. I could not be more grateful, and I actually see a hope in the future for the first time in my life on this issue. So thank you all to everyone, and thank you so much for sharing your time with me.
Thanks, Derek.